Morning.
My name is Sherene, and I'm going to be presenting my capstone, which is on preventing post-traumatic stress disorder in critically ill patients. Can I see a show of hands? How many of you have been in an intensive care unit before?
Like to visit or working?
Visit, working? Okay. Anybody over here ever been in an intensive care unit before? Intensive care units tend to be quite kinetic, and the patients that are there are actually hooked up to quite a bit of machinery, things like that. Has anybody ever seen people hooked up to a whole bunch of machines?
Oh, yeah,
Yeah, okay. Even on TV, you've seen people hooked up to a whole bunch of machines. Has anybody ever seen a patient who is delirious, having hallucinations, acting out because they're confused? A lot of those kind of things are related to delirium that can lead to post-traumatic stress disorder. So after a particularly hard night at work, I had taken care of a patient who was really confused and having a really difficult time and begging to be let go, thinking that people were trying to attack them. I was walking through the hallway, about to walk into the door of the ICU, and I looked up at the ICU door after, dealing with this traumatic event, and thought to myself, really honestly it should say, abandon all hope if you enter here, because sometimes those intensive units are that stressful, they are that difficult, and the poor people that go through these horrific procedures, I don't know how they ever are the same afterwards. So my objectives. My objectives are that after this presentation, you'll be able to define what post-traumatic stress disorder is. I want you to understand what the effects of PTSD are on patients, describe current interventions that we can put in place to prevent post-traumatic stress disorder, list ways in which research has shown that it can be prevented, and to identify those patients who are most at risk. Okay. So when I did this research, I found that there were multiple key terms that I needed in order to get the information that I needed. So because of that, we're only going to focus on 3 key terms in the presentation, but in your packets, there is a rather lengthy list of the different key terms that I had to use when I was preparing the talk. So the first one is post-traumatic stress disorder. So post-traumatic stress disorder is an anxiety disorder that arises after a person experiences a traumatic event that causes them to experience feelings of extreme fear, helplessness, or horror in which they perceive a threat or an actual possible threat of death or injury to themselves or to other people. The second key term that we're going to focus on is delirium. Delirium is a sudden onset of confusion due to rapid changes in brain function that occur with physical or mental illness and can be caused by alcohol or sedatives or drug withdrawal, electrolyte imbalances or chemical disturbances in the body, infections such as urinary tract infections, pneumonia, or sepsis. It's more common in people who have already had some sort of brain damage, whether it be from a stroke or dementia, people who have toxins in their system, or people that undergo surgery, because if you think about anesthesia and its effects on the brain and the body. So here are some symptoms of delirium. According to the research done by Johns Hopkins University in 2013, there is evidence to suggest that ICU delirium may be a significant risk factor for post-traumatic stress disorder. Acute lung injury patients who receive benzodiazepine or opiates for sedation suffer from agitation or physical restraints, often develop to delirium and coma. Researchers theorize that during the hyperdynamic phase of sepsis, the cytokine release from the damaged blood vessels created a permeability of the blood-brain barrier. This allowed for toxins to cross over into the brain and added more delirium to these patients in coma. Of these patients, 62% of these patients after discharge still had symptoms of post-traumatic stress disorder. So it's pretty important that we get a handle on it and try and help these people out, because it does significantly impact their life. So this is a video of a woman who experienced delirium during her stay in the ICU and consequently has some symptoms of post-traumatic stress disorder.
creatinine from a kidney problem was high, and my doctor at home thought that I should come and I had a biopsy done. And that's the last thing I remember. The next thing I knew, I was waking up having some very bad feelings and bad thoughts, and wondering why I was there and not knowing how I got there. I remember when I was intubated that I was having delusions. People weren't there. There were aliens there. There were good ones and there were bad ones. And I had a stone, a crystal, and I had to make sure that crystal got to the right person. And these things were trying to hold me from getting the stone to work. So I was going to go, half of them were human, half alien, and I had to determine who was good and who was not good. And I wasn't finding them. I was just trying to get the stone to where it's supposed to go. And there was a robot in it who, every time I would make a mistake, he'd take me back to the beginning again and had to scan me again. And I had to go through the same process of trying to find out where I'm supposed to be and what I'm supposed to be doing. I know it didn't happen. But it was in my mind, and to me, if something happens in your mind and you see it, it happened. Whether it happened physically or mentally, it happened. My biggest fear right now is not the procedure itself or the problem itself. It's the going through the nightmares. They're terrifying. No one should have to go through that. No one. Talk to them, take time to see what they're trying to say. Keep diary. I'm going to ask you about what went on, and I want someone to be able to tell me when. And it's better if it's written down, just soothing words, soft music, something soothing, because I'm probably fighting a battle in my brain.
So it's interesting, every time I see that video, I see something different that makes me think of how much we as nurses play into this and cause this delirium, which was talking about that she had to keep getting rescanned to make sure she was doing the right thing. I wonder, when we administer medications, we have to scan their name bracelet. And a lot of times I'll walk into the room and say to the patient, I need to scan your bracelet. If those kind of things play into their mind, because it's such a foreign concept to them. You think about, she said that she was intubated at the time, so she was on a breathing machine. So she wasn't able to communicate, and she was sedated. And here she is laying there, and we're walking in the room saying, I need to scan you now. Can you imagine what that does to your brain when you're not used to that kind of technology, and people are coming in and saying these foreign things to you, how that adds in? So, it's very interesting. So this is a graph that shows us that 52% of patients have absolutely no recall of their ICU experience. Those are the lucky ones, actually. 23% recall only delusional memories or dreams. The other 23% only have memories of the painful procedures that they underwent while they were in the intensive care unit, and 2% of them have total recall of what happened to them. Our next key term is patient diaries. So patient diaries are a relatively new tool being utilized in a very few ICUs globally. The goal of patient diaries is to help prevent post-traumatic stress disorder by filling in memory gaps and by clarifying those delusional memories and dreams that they have. They help to document what happened during the patient's illness. They help patients piece together those missing areas and to clarify those dreams. Some of the diaries included photographs of the patients. Some of them included photographs of equipment. It helped them to understand how critically ill they were and helped to prepare them psychologically for a really lengthy recovery process. So here I have a global map of the world, and it shows you the different ICUs where diaries are actually being utilized. These are actually individual ICUs. You'll see that there's not a lot of them using diaries when you look at it on this particular scale. Now this is up to date. But you can see over here in Europe, there's quite a few people using diaries. Down here in Australia, there's some people using diaries. These are actually individual ICUs. So the red indicates a contact person that you can contact to. No. The red is a contact person. The blue is an ICU currently using a diary. And the green dots are ICUs that are actually studying a diary being used and how it's affecting their patients. So if we look across the world here, come over here to the United States. Oh, there's another one hidden. That's it. That's it. That's all we have in the United States. These are individual ICUs. So this is a tool that has shown to help patients combat delirium and post-traumatic stress disorder because how much it's being used. Yeah. So for an overview, patients go through extreme stress when they intensive care unit, and this stress can result in long-lasting psychological damage to them. Implementing a plan of care that embraces relationship-based care to change policies in the intensive care unit will decrease anxiety that patients and family members experience in this time of crisis, and therefore decrease the incidence of post-traumatic stress disorder experienced as a result of their stay. Common psychosocial symptoms after discharge from the ICU. They have depression, they have anxiety, they have panic attacks. Post-traumatic stress disorder, obviously, this is my paper's about. A lot of them feel guilt. They feel like they're a burden on their family members because they were so sick, and they think about the time that they spent in the hospital, the costs that it takes to care for them. They feel really guilty. And then afterwards, typically they have a really long recovery period, and they feel like a burden on their families. They lack of confidence. If they're young enough to be able to engage in sexual activity, they have a lack of libido. They're irritable. They have poor memory. They have difficulty with concentrations. They feel very socially isolated. Again, they're not able to go out and do the things that they used to be able to do before they got really sick. A lot of times there's marital difficulty. If you think about the financial impact on families and how critical illness can affect them, it does often create difficulties in marriages and obviously the financial difficulties. The cost of an ICU is just phenomenal for just a one-night stay. Can you imagine if you're really ill and you stay there for a month, attached to a bunch of equipment, everything that gets attached to them costs more money. So background, incidence of the problem. 1 in 3 people who spend time intubated in the ICU develop post-traumatic stress disorder symptoms. 35% of those people had clinically significant symptoms at their 3-month visit follow-up. And then another follow-up at 2 years, 62% still had symptoms. What we know about the problem, patients with depression pre-hospitalization are more likely to develop post-traumatic stress disorder. Patients with sepsis receiving opiates for sedation or benzodiazepines were twice as likely, or also more, likely to develop post-traumatic stress disorder. Patients experiencing delirium were more likely to develop post-traumatic stress disorder, and patients receiving corticosteroids were less likely to develop it. And they theorized the reason for that was because it decreases inflammation. So the decrease in inflammation may cause less symptoms. So my PICO statement. Population obviously is ICU patients. And my intervention is to create a relationship-based plan of care to help address as nurses some of the issues that we have under our control to help these patients. Our comparison is none. Although it says on my slide the comparison is none, some of the interventions that I suggest are part of what's going on in ICUs already. There isn't a specific plan of the different interventions that I suggest that anybody's doing in its entirety, but a lot of these ICUs are starting to realize that if they implement some of these aspects, it does help their patients have a better outcome. And obviously my outcome is to reduce the incidence of post-traumatic stress disorder. So my research question, will implementing a relationship-based plan of care in the ICU help prevent or decrease the incidence of post-traumatic stress disorder experienced by patients? So my background theoretical model was relationship-based care. I thought that it encompassed values that were important to making sure that the patient got the care that they needed. Relationship-based plan of care is a model that includes key elements of relationship-based care for nursing by creating a caring and healing environment, encouraging nurse leaders to strive for positive change, fostering teamwork between the interdisciplinary healthcare team that includes the patients, the family, the staff. That's really important. The patients and the families are included in this particular plan of care. They need to be consulted. They need to be part of the team. The plan of care should embrace professional nursing practice with nurses who are competent in caring, who strive to utilize all the resources in their delivery of care, including staffing, time, equipment, and an economical budget. The interventions that I have suggested don't cost really any money. Maybe the diary costs a little bit for some paper, but other than that, it doesn't really cost a lot of money. The plan should examine measured outcomes to ensure that they are continuing to move forward and striving for what is in the best interest of our patients. So the review of the literature methodology, I did use multiple databases and multiple keywords, which you have in your packets, to research this particular area. I had to go quite a few different places. And there's more and more research coming out every day. Every time I get on the internet to look for one little thing, another article pops up. I'm like, oh look, there's another one. So this is a graph of some of the articles that I looked at. These are 7 studies that showed how anxiety, cognitive problems, delirium, memory gaps, prior mental health diagnosis, sleep disturbances affected patients. And if you look, you can see that, cognitive problems, delirium were definitely high up there on the list. Prior mental health, there was only a few. This article here addressed all of these areas that I thought increased post-traumatic stress disorder. It focused on all of them. All the levels of evidence were provided by Lobiano, Wood, and Haber, 2010. This graph here encompasses 10 articles. These are the different aspects that I focused on for creating my plan of care. So the first one that I wanted to implement was open visitation. The second one I wanted to implement was a nurse liaison. A nurse liaison basically is a person who's put into the family to the patient to help them with decision making, especially if the patient is very critically ill or possibly coding. Palliative care consults need to be implemented in all patients. Palliative care has gotten a bad rap over the years. They think of it as the death team. In reality, palliative care helps people to deal with the symptoms of their illness and pain and issues relating to their illness, how they're going to achieve rehab, all different aspects. And it needs to be utilized more. It is a huge resource for patients and families. Patient diaries. Family presence during resuscitation was also really important. Screening for post-traumatic stress disorder was another one that was pretty important to identify those who were more at risk. Was really, really helpful in getting them the care that they needed. So you can see 3 articles right here were definitely 4 patient diaries, and then 4 of them stated how important it was to do screening of those patients to identify those who are at risk. So theme 1, patient diaries. According to Ehrgard, Schwartz, Nielsen, Hansen, and Lackner in 2007. They discussed how many patients develop post-traumatic stress disorder as a result of their stay in the intensive care unit. They stated that patient diaries could be used as a debriefing tool for patients to help them understand the extent of their illness and fill in their memory gaps. Diaries gave more patients a more realistic expectations of their rehab requirements. According to Johns Hopkins University in 2014, research has shown that during the first 3 days of a severe illness the patient spends in the ICU, he or she can expect a 9% decrease in muscle size. That's pretty significant. So think about if you're in the hospital for a month and then you want to try and get up and walk, it's not going to happen. You're not going to be able to walk. You're going to be very, very weak. Many of those diaries included photographs of the most common equipment in the ICU and explanations of what they were used for. Researchers went on to say that some of the diaries were written by nurses only. Others were used by the entire healthcare team. So the physical therapists would come in, the physicians would come in, the nurses would come in, and they would all write in the patient's diary explaining what they did with them and what happened with them during their stay. It also served as a means of communication for family, as well as documentation of the patient's events. None of the units attempted to assist the patient to write in their diary on their own. And the rationale was that patients, even if they were awake, were not able to focus properly on these diaries, whether it was because of ocular edema or confusion, whatever the reason was, they thought that they couldn't actually focus to write. A lot of times because of that muscle weakness, their handwriting was way too shaky and they were unable to hold a pencil properly or a pen properly to write in their own diary. Ehrgard et al. 2007 stated that diaries should be started on admission to the ICU, even if the patient was expected to have only a short stay. The patient diary is considered a therapeutic nursing intervention with the goal of helping patients to remember after a critical illness. So my next theme 2, screening tools. So there were 4 screening tools that I came across that I thought were really important. The first one was the Hospital Anxiety and Depression Scale. The second was the Impact of Events Scale revised, the Post-Traumatic Stress Scale 10, and the UK PTSD 14 scale. So the literature search revealed several scales. They looked at patient anxiety levels and symptoms of post-traumatic stress disorder. The first one, the Hospital Anxiety and Depression Scale, is a self-assessment scale developed to detect states of depression and anxiety in a hospital setting. The Impact Event Scale revised is a 22-item self-reporting measure that assesses subjective distress caused by traumatic events. The PTS-10 scale assessed symptoms of post-traumatic stress disorder in the hospitalized patients, and the UK PTSS-14 scale was a scale that was an updated version of the PTS-10 scale. It incorporated aspects of the HAD scale and the Impact Event scale revised. It was easier for the patients to complete because it was shorter. It wasn't as long as the 22-item one. And Twig, Humphreys, Jones, Bremmel, and Griffiths, 2010, decided to implement this scale in their research when they were researching post-traumatic stress disorder. So the scale asked the following questions. It asked, I presently suffer from sleep problems. I have guilty feelings, nightmares, unable to love, depression, I feel dejected or downtrodden. I avoided situations that reminded me of the intensive care unit. I felt jumpy, I was easily frightened by sudden sounds or movements. I felt the need to withdraw from others, I had fear of places, the images in my intensive care unit, irritability, easily agitated or annoyed, frequent mood swings, a bad conscience, they either blamed themselves or others, they felt numb, couldn't cry, they had muscular tension, and they avoided places or people or situations that reminded them of the intensive care unit. These were all based on the Likert scale. Obviously, 1, they didn't have a lot of symptoms. 5, they had quite a few symptoms of post-traumatic stress disorder. So the strengths of the literature helped to point out and recognize what the certain patients were that were most likely to develop post-traumatic stress disorder. So we found that acute lung injury patients who were intubated were more likely to develop it. People with a past history of mental illness, people who were sedated with opiates or benzodiazepine, patients who already had delirium or developed delirium, or whether it be sepsis or some sort of infection like urinary tract infections. I think we talked earlier about those urinary tract infection patients who get confused and act out. Lack of sleep hygiene. If you look at an ICU, if you've ever been in an ICU, typically we wake you up every hour to every 2 hours to assess you, which is really difficult. Can you imagine being there for days and somebody waking you up every hour to make sure you know who you are and where you are and what's going on? Our neuro patients have a lot of problems with that. When you think about they already have a brain injury and you're waking them up every hour to make sure that they're still in there. They end up getting confused pretty quickly. And then it's a difficult battle trying to figure out, are they confused or is this a neuro change? So it becomes really difficult. And sepsis. Sepsis plays a huge role in development of post-traumatic stress disorder. So our weaknesses. Continuing research needs to be conducted to support the suggested aspects of the plan of care. You can see the levels of evidence that I had. Some of them weren't so strong because, again, it was that subjective qualitative data rather than quantitative data. So because of that, it made it a little bit difficult to find some really good, hard research. It's still a very grassroots project. There are a lot of people looking at this particular aspect of care, and they're just starting to recognize now how much it impacts patients. I mean, we see them in the intensive care unit, and they either survive or they don't. If they survive, you ship them out, and then that's the last time you see them. That whole aspect of their care ends. So you don't see those long-term aspects afterwards. And we're starting to realize that we really need to take a look at what we could do in the ICU to help prevent these problems from occurring. So according to Provision Code 3 of the Code of Ethics from the ANA 2011, patient advocacy requires nurses to support and protect their patients. With all that we know about post-traumatic stress disorder arising from intensive care unit stay, it is the nurse's moral obligation to do everything that we can within our reach to prevent patients from suffering from this debilitating illness. These things that I'm suggesting aren't that difficult. They don't cost any money. Why aren't we doing them to help these patients? Because it's difficult for them. We should be looking at how that's going to affect them later on in life. If you think about it, if you're intubated in the ICU, you can't talk. You have a tube down your throat. It goes through your vocal cords. You can't communicate. So one of your ways of communicating are gone. If you have a family member who knows you really well, they're going to be able to advocate for you. And they're going to be able to understand you better. I can't tell you how many times I've stood over a patient who's tried to mouth words to me, and I had foggy some of what they're trying to tell me. And they get frustrated, and they get angry. And then you hand them that piece of paper and that pad, and they try to write something, and it's just a whole bunch of scribbles because they have that lack of muscle mass and they cannot physically hold that pen well enough to write something, or they can't see what they're writing. So it's very frustrating to them, and you can imagine how difficult it is and how much more anxiety that brings in for them when they can't tell you something simple like, I'm cold, I have pain, I'm hungry. Just those simple basic things, I'm scared. They have no ability to communicate that. Luckily, we do have some communication boards, which are helpful, but if you can't see, to point at what the board says, it's of no use to you. So it's really important to have family there because they can understand you a little bit better than not. And having family present and incorporating them in the healthcare team decisions plays a huge role. Those diaries for afterwards are huge for those patients. We had a patient in our ICU that's a nurse who works on a different floor who was with us for a while, and she was intubated. And her friends decided to create a diary for her, not because of the research that I'd done. It was just something that they wanted to do on her behalf. And she stated that after she was discharged, that diary did help her tremendously. She could go back and look at who came to see her and what happened to her each day. And it helped clear up a lot of different things that she was having struggles with trying to remember. She had lost a lot of the memory. And then she had thoughts of things that happened that actually didn't really happen. So again, my recommendations: to build relationships between patients, families, and caregivers, the open visiting hour policy so that families are present for that patient, palliative care consults, allowing families to be present during resuscitation, and that's kind of what you're probably wondering, why is that with the patient? Well, it helps the family. And if you think about the anxiety the family feels and how they project that to the patient, if they're there and you have that nurse liaison that's there to help explain to them what's going on, it helps to decrease their anxiety, and they're not projecting that towards their patient. So if they're more calm, then the patient is going to be more calm. If you think about it, if your family is very, very anxious about what's going on, you're going to feel anxious too, especially if you can't communicate. You see that they're upset, think about how much more anxiety you're going to feel. If you can't communicate, you don't know what's going on, you see that your family's upset. And implementing the use of patient diaries. And the use of a screening tool to identify those who are most at risk. Again, another key term key way to help decrease anxiety in patients and decrease post-traumatic stress disorder. So here are my references. Any questions?
CCRI, is
Correct.
there any movement in that practice group to promote this?
Actually, there is quite a bit of literature out there that TCRN has done on it. They have articles in their magazines. If you get them in their magazines, there's lots of articles posted on preventing anxiety and development of post-traumatic stress disorder. I was amazed to see that Johns Hopkins is doing a lot of research in that area. They're calling it post-ICU syndrome. They're not labeling it as post-traumatic stress disorder, but it is the same thing. It's just a different term that they're using. But if you look at if you go to the website, the critical care website, and look and search in their toolbar, they do have lots of articles that pop up regarding post-traumatic stress disorder in critical care patients. A lot of that, it will get relate back to those patients who are receiving sedation, those acute lung injury patients that have hypoxia, those septic patients when they have that whole cytokine release that destroys that blood-brain barrier, lets those toxins from whatever bacteria they have into their brain or the medications that we're giving them into their brain to sedate them. A lot of our patients now in the ICU that I used to work at, the hospital I still work at, are neuro patients. We have a huge focus on neuro care right now. Those patients we aren't sedating, obviously, because we need to be able to assess them and assess their neuro status. And I'm seeing a decrease in the amount of post-traumatic stress symptoms with those patients because we aren't using sedation. We're trying to do that across the board. If they put them on sedation, they keep it really, really light. They're trying to decrease the use of restraints, so we have volunteers that come in and sit with the patient. Well, not volunteers anymore. They have to be. They found that the volunteers weren't great for keeping the patients from pulling tubes out, so they have nursing assistants come and sit at the bedside because they have to be able to be hands-on. Whereas our volunteers couldn't touch the patient, so if they grabbed something, all they could do was yell for help, and it didn't stop them from ripping things out. But they're doing a lot more work to try and decrease this. They finally just opened up visiting hours, so we have visiting hours 24/7. We do bring a lot of our patient families in when we're coding a patient. It's a mixed bag. We usually try and designate a nurse to stay with them, but if you look at our code sheet and we have everybody assigned a role, there is no nurse liaison role. It's just somebody who pops into that role, and they really should have some specialized training for that.
So we know that you have been accepted to the NP Postmasters program for psych at Stony Brook. I don't know if you knew that. She started yesterday or Thursday. Are you planning to continue this specifically? What are you planning to do with this?
I would love to continue this specifically because I have a huge love for critical care. Obviously, if you look at my resume, which is in a couple of your packets, I've worked primarily in critical care, and I've just started working as a nurse educator, and I luckily still have contact with the critical care unit, so that's great because I think I would miss it terribly. But I got a text from them today that they have a subarachnoid hemorrhage that's very, very sick. On ECMO, continuous brain monitoring. I have no idea. I'm very, very ill. Whether I'll be able to or not, I don't know. They did specifically want to sign me up for a grant, which comes with a stipend, but it's primarily focused on youth and suicide prevention, so I don't know if I'll be able to continue this particular research, but I certainly hope that in the future I'll have that opportunity. It looks like I may be English cost doing clinical at Strong, and so the person that I contacted at Strong, I did tell her that I had a pretty strong critical care background and that I wanted to focus on neuropsychiatric care of patients, so I'm hoping that will be an in for later on if I'm able to get into an adult program and still continue to do clinical with them. But we'll see. Right now I think I'll be taking a different path, which I wasn't expecting because you all know that I'm all for the adults and the little people kind of scare me. So taking on this grant where I'm going to be actually looking at adolescents and youth is kind of scary to me, but we'll see. So